Leo, if you just let me know when we're ready.
Yes, almost there. You should say recording in process.
I'm sorry, before it was letting me onto a link for many minutes, but it looked like it was the attendee one. So I couldn't speak to you or say anything.
Oh, that's why. Sorry
Yeah.
about that. Millie, are we recording or? Hi, everyone. Welcome to our Monty Hart lecture series. It's a great pleasure to have today Dr. Sanjay Prasad, who will be talking about dilated cardiomyopathy, phenotype to genotype, and back. Dr. Prasad completed his medical education at the University of Wales in Cardiff, and then continued his studies at Harvard University in Boston, where he was a Fulbright scholar, and then he undertook medical training in London and Geneva. He's a professor at the National Heart Lung Institute at the Imperial College of London and leads a large cardiovascular research group. His team has published more than 200 papers, including New England Journal of Medicine, Lancet, JAMA, and Nature, and has helped to inform national and international guidelines. If you've been following the publications on dilated cardiomyopathy, in particular in cardiac MRI and genomic phenotyping, you've seen his name in every big publication. So it's a great pleasure to have you here. I'm very excited for this lecture.
Thank you very much. It's indeed a great pleasure to be there. I'm so sorry I can't be in person, but thank you for the invitation. So with dilated cardiomyopathy, when we think about what the clinical issue is, what we want imaging or genetics to think through, it's really very interesting and important to think through what are the big unmet needs. And the big unmet needs are very straightforward. It's what are the questions our patients are asking us? What are we thinking when we're seeing patients with dilated cardiomyopathy in clinic? And there are some very clear and obvious ones. The most obvious one when we see our patient is, are they going to get better? Are they going to get recovery? Who does well, who does badly? We have great medications, but there is still an element of flipping a coin and thinking, are they going to show an improvement in function when we commence them on the Fab4 medications, or are they going to adversely remodel? Secondly, we need to improve our risk stratification. Who really benefits from an ICD versus who can be managed more conservatively? If they improve their function with treatment and previously have had a low EF, does that put them in a low risk group, a high risk group? If they've got lots of fibrosis, does that mean they get an ICD? There are many unmet questions that need addressing. And then a common question is, why have they developed dilated cardiomyopathy? Unlike patients with coronary artery disease, who often tend to be much older, this is a young demographic cohort. They're often patients in their 20s, 30s, they've been well, and then suddenly they've developed symptoms of breathlessness or rhythm disturbance, and the question is why? Another question that's very interesting is we'll have patients that are treated, and then after 5 years, their function is completely normal. They're on meds, but their BNP is normal. They're asymptomatic. NYHA class 1, BNP, other markers, exercise test is normal. And the question is, can they come off their medications? So are we seeing remission, or are we? And ultimately, our goal really is two things. One is, how can we tailor and taper our therapy much more strategically with a precision or personalized therapy approach? What drug to what patient at what time? And secondly, how can we pick up the disease at a much earlier stage? I think the word that's very much in vogue at the moment now is interception. At what point can we intercept in the disease process before the patient has even developed the symptoms? If someone comes in class 4, they're very, very breathless, we've missed the opportunity to really help them. To quote Sun Tzu, The Art of War, the best way to win a war is to never fight it. And if we know that some of these patients have a genetic predisposition or etiology, what can we do to mitigate their risk of developing the condition by early detection and early interception? I think that's really one of the key goals going forward. And it's important to emphasize that this is not a doom and gloom story. Patients have really done very well. If we look at, this is work from the Trieste cohort that looks at what's happened in terms of mortality and survival rates, this is very much a good news story. If you look at all-cause mortality, it's dropped significantly. And what's made that difference? Well, it's the introduction of medication, good guideline-driven, evidence-based medications that have made a massive difference. So pump failure is down, all-cause mortality is down, but there is still work to be done. It's not that everything has improved completely, but there is a dramatic improvement. And whilst this is slightly dated information, one can anticipate that these numbers are only going to get better with the introduction of the SGLT2s and Entresto. So in terms of risk, this is one of the biggest challenges. Who should get an ICD, who shouldn't? At the moment, we don't have a crystal ball. It's not a precise science. We know from the Danish study that there is a subset of patients that do benefit from an ICD. There is a reduction in sudden cardiac death within a subset of patients. But the challenge is that when you look at all-cause mortality or overall survival, then we're not seeing a significant difference. When you then explore and deep dive into that and look at who are the patients that do benefit, there are certain subsets, for example, based on age, based on biomarker profile, where certain subsets of patients do better than others and do get that benefit. But overall, no survival benefit. So in terms of our current tools, again, if we look at many of the guidelines, again, they talk about, they give a gray zone where certain patient groups seem to be high risk, but there is a lot of patient cohorts. What happens to the 35 to 50%? Is it all patients with an EF below 35% that benefit? So there's a number of gray zones where our evidence base is not yet strong enough. The other challenge that we have in dilated cardiomyopathy is that whilst we identify those that are at highest risk, i.e. those with a low EF, poor function, NYHA class 3-4, from a sudden death perspective, the bigger issue is that actually the population that has the highest burden of sudden death is actually those with mild to moderate reduction in LV function. Why? Because they represent the greater cohort within the community compared to those at highest risk. So how can we better define the patient at risk, and especially before they've declared themselves with an arrhythmia? So our current paradigm has very much been run by ejection fraction. This has been the mainstay for many of the clinical trials, but there are limitations. It's limited by loading conditions, by heart rate. It turns out to be a better guide for all-cause mortality rather than sudden cardiac death, and then there are issues about reproducibility. So we've seen from several studies, Oregon and the Maastricht series, that there is a need to try and define better paradigms for risk stratification than ejection fraction. And there are many challenges. We talk about dilated cardiomyopathy, and we tend to think of it as a very homogeneous condition, but increasingly, as we look at dilated cardiomyopathy, we're realizing that it's very much a homogeneous end phenotype, but with a highly heterogeneous underlying etiology, ranging from idiopathic, where we never identify the cause, to genetic, to inflammatory, environmentally driven. And increasingly, we see that when you look at the Venn diagrams of the causes, there is significant overlap. And these are things that we will cover in this talk. So what we thought was a viral etiology, now we're realizing that 10% of myocarditic patients will actually have a genetic predisposition. And that's important because it means two things. One is that this is no longer just a random bad luck issue that patients have had the condition, but it also means, secondly, that we have the opportunity to cascade screen family members and identify those at risk before they've developed the condition. So interception, again, this concept that the best way to win the war is to never fight. The other thing is that the etiology historically has had an impact. So certain patients, certain patient groups do better than others. So knowing what the underlying cause is can be important. And this is work from the Trieste cohort where they identified that there are differences in outcomes based on the dominant etiology, whether it's alcohol-based, chemotherapy-based, tachycardia or genetic versus idiopathic, showing that we can't use this as a one-size-fits-all approach, but also recognizing that on that Venn diagram, there is much overlap in terms of etiology. So what was thought to be pure alcohol-induced, we realize a subset has a titin mutation, for instance, and again, things that we will cover in this talk. So from a risk perspective, the other big challenge is that of competing risk. So what is their risk of sudden death? versus what is their risk of competing with sort of non-sudden death, particularly heart failure or other causes in an elderly population. So this is something that guidelines need to address and to think through. And the good news story here is that we do have tools to guide that understanding, ranging from the insights that have been gained from a genetic predisposition perspective to what's happening at the structural level. I have particular interest in fibrosis that I will talk about during this talk, to what's happening from an electrical instability perspective, but also what are patients declaring themselves with. So do they have diabetes? Something like 25% of our cohort will have diabetes, about 20% will have hypertension. So making sure that we address that comorbidity factor as well when we look at these patients and address them. So what does success look like from a risk stratification perspective when we think of that arrhythmic risk? First of all, the ideal would be that you've got an individualized risk stratification. Two is that it combines better characterization of the underlying etiology, and that we take that personalized approach. Three is that none of this data lives in isolation, in a vacuum. We now have a multitude of data sets. You'll have the basic clinical demographics with biomarkers, with imaging data, with genetics. And if the promise of proteomics and other omics comes true, we'll have layered data sets. And the challenge is that harnessing that at a practical and clinical level, but most importantly, at the outpatient level, has to be key. So knowing how to use technologies, machine learning type approaches, for instance, that embraces that multi-parametric risk stratification is going to be important. The other thing that I think is interesting is that we tend to stratify patients when we see them, but of course, their diagnosis and their remodeling changes over time. So we need to have better stratified risk markers that are time dependent, that identify how patients evolve from high, low risk groups over time, rather than a single time point. So going back to basics, what is it that predisposes these patients to sudden death? Well, again, it's not a one-size-fits-all approach. There are many things, so structural, genetic, and then the acute triggers, whether that be PVC or acute localized ischemia, and then neurohormonal autonomic changes that all play a fundamental role in triggering that. And as we use that data and as we build that knowledge, it's a really important point to take home one of the messages that we've learned from some of the gurus in machine learning, that every model that we will build is wrong, but some have utility. So how can we recognize that no model will address every factor, but at the same time know what's actually useful at a clinical level? How can we embrace what's meaningful as opposed to what's interesting but isn't going to impact and change management? So it's using the models in a clinical, meaningful way, where our clinical endpoints are what drive the models that we use and show that interception or intervention as utility. We've got a good paradigm, and whilst there are proponents and opponents of the HCM risk score, it provides a starting point. It provides something that you can use that's meaningful, that patients can relate to, that provides the general cardiologist with some sense of, do you have a high or low patient in front of you when you're seeing someone with cardiomyopathy? And really, I think the goal is, how can we develop something similar in the dilated cardiomyopathy? So again, a number of groups have looked at this. There are a number of different scores that try and address this. This is one example where they looked at just under 1,400 patients, median 57-month follow-up, and they identified parameters that seem to be predictive, so gender, age, whether they've already had an arrhythmia, family history, QRS duration, EF, seeming to be important predictors. And using that information from a net reclassification perspective to see how can we improve patient stratification, and using a score like that, 15% fewer ICDs, if we apply that algorithm. But it needs to be tested in broader cohorts in different patient populations before it's anywhere near ready for prime time. But it shows a starting point in addressing the clinical challenge. So C index of 0.72. And again, compared to guidelines, 15% fewer ICDs. From our perspective, we've taken an interest from an imaging perspective in the role of fibrosis. Why fibrosis? Well, we know that the presence of scar tissue in the myocardium predisposes patients to reentrant arrhythmia, and therefore sets up circuits to cause major ventricular episodes. And so we some years back, we looked at just under 500 patients respectively recruited with dilated cardiomyopathy, and we looked at them based on the presence or absence of fibrosis as determined on a cardiac MR scan, a late gadolinium enhancement scan. And this shows an example from the study. So we give gadolinium contrast. We're identifying significant mid-wall late enhancement in this patient cohort, in this patient example, and that validates with the explanted heart, the post-mortem explanted heart, where we're seeing almost identical delineation between what's seen ex vivo and what's seen in vivo. So replacement fibrosis. And that pattern, that mid-wall pattern of fibrosis, as you will all be aware, is very different in the ischemic setting with the subendocardium that's predisposed. And what we identify in this cohort is that if our current paradigm is ejection fraction, that's the blue dotted line, it serves us reasonably well in terms of predicting who is at high and low risk of major arrhythmic events. The endpoint here, sudden cardiac death, reported sudden cardiac death. But the mere binary presence or absence of fibrosis is very helpful in delineating who's higher risk versus who's a low risk within that subset. So the mere binary presence of fibrosis portends a much worse prognosis for any given level of ejection fraction compared to patients with no fibrosis who fall into a lower but not zero risk group. The net reclassification index, their improvement was about 0.29. The other thing that's interesting here is that fibrosis data extends to patients with mild to moderate levels of LV dysfunction. So when we look at patients with an EF of 40 to 60%, again, we're seeing that the binary presence of mid-wall fibrosis, again, portends something like an 8-fold greater risk of major arrhythmic events compared to patients without fibrosis. So on the basis of that, again, a number of meta-analyses all highlighting that the presence is associated with increased risk of major arrhythmic events. And on the basis of this, a number of groups have looked at how we can harness this information to improve risk stratification within the clinical setting. So this is one group, this is from Matthias Schmidt in Manchester, where they looked at patients with and without fibrosis, with and without certain levels of ejection fraction. And what they do is they identify a very high risk cohort, so patients with an ejection fraction below 25% and with fibrosis, below 20% ejection fraction and with late enhancement form a very high risk group, with patients who have an ejection fraction greater than 35% and no fibrosis fall into a much lower risk group. Again, none of this is zero risk, but it's a much lower annual risk group. And then an intermediate group where they will have ejection fractions that may be low, but with no fibrosis. So this at a clinical level is a really useful tool for how we can harness this information at the patient level and at the clinical level. So this just kind of shows an algorithm that they propose for bringing in that data. Who falls into a low risk group, annual event rate 0.2% versus a high risk cohort, annual event rate 7.2%. And then importantly, that gray zone cohort that is always challenging, and how we can better delineate who is at the higher end of the spectrum, who's at the lower end of that spectrum in that sort of borderline gray zone. And then based on these findings, again, there's a number of studies. CMR Guide is one where it looks at patients who don't meet conventional criteria for an ICD. So those with ejection fractions that are above 35%, both with an ischemic and a non-ischemic etiology, and then randomizing them to either an ICD or a loop recorder. So this is led by Joseph Silvernaim in Adelaide, and we've now finished recruitment for this study of over 300 patients who were randomized to either an ICD or a loop recorder, and they're now in the clinical follow-up phase. So it'll be interesting to see, can we use that the presence of fibrosis within that cohort, which is the key parameter, as a way of not just showing risk, but also changing management. There's also the DCM British study, which is about to start. This is led by Andy Flett, where they will take patients with low ejection fraction, with fibrosis and randomize them to an ICD or not. So this will be a really important study. It's taken many years to get this funded, but this will really be an important study in guiding management that will take a number of years to deliver. But it shows how the concept of fibrosis is now being driven into the RCT to form the gold standard for how we harness and use this information. The other thing that's interesting is thus far we focus very much on late enhancement and replacement fibrosis, but we also know that these patients are at increased risk of interstitial fibrosis, so the finer networks of fibrosis. And again, from an imaging perspective, there are ways of mapping this using T1 mapping, extracellular volume fraction. And a number of studies have looked at this to give parametric maps of the presence, the amount of interstitial fibrosis over and above any replacement fibrosis. This is from a group in Beijing, from Minji's group. And again, what they show is that patients that fall into certain tertiles or certain levels of elevation in their ECV fall into a higher risk group compared to patients with low levels of ECV. And this is in conjunction with their LV ejection fraction. And so a model that seems to be a good predictor of adverse outcomes in conjunction with changes from their late enhancement. Another group, again, Matthias Schmidt from Manchester, has also looked at how we can use this information for risk stratification. And what they identify is that there are cohorts of patients with ECVs below 30%. And again, they use this to identify that you can delineate patient groups into a higher and lower risk group, and then an intermediate risk group. And they bring this again into an algorithm to identify your high-risk cohorts, so annual event 7.5%, they've got a low ejection fraction, they have late enhancement, they have an ECV above 30%, a low-risk group who have pretty much the opposite of that, and then an intermediate risk group, 2%, where they have an EF greater than 35%, they have late enhancement, but they have a low, an intermediate level of ECV reading. So this, again, can be a useful tool in identifying patient groups, stratifying who gets an ICD or not. But again, the real test will come as we get the RCT data over the next few years. So moving forward, a number of groups have looked at other aspects of late enhancement. We tend to focus on what we can see, but there is great richness in that late enhancement imaging, in the fibrosis patterns. It's not just about is it there, but as our electrophysiology colleagues will tell us repeatedly, channels that form within the areas of scar tissue, the surface interface between normal myocardium and the area of scarring and the gray zone, all have utility in identifying patient risk. And so a number of groups have looked at how we can take computational modeling analyses. This is work from Natalia Trianova at Johns Hopkins in predicting that risk pattern. And we've also taken an approach where we've looked at that interface and electrophysiological simulations to predict the arrhythmic events, to go beyond what we see visually. And again, you can simulate the electrical pathways, and on the basis of that, you can identify patients that fall into a higher and a lower risk group based on those pathways and the interface that's being seen between these normal myocardium and fibrosis. So I think that will be useful going forward as we bring in machine learning, as we use AI type approaches in harnessing the richness of the data, not just imaging, but also other aspects of data that are present. The other reason why I think interstitial fibrosis is important is that late enhancement for replacement fibrosis is very much you've either got it or you haven't. It's not a reversible entity. But I think the attraction of targeting interstitial fibrosis is that potentially it is a reversible etiology and a reversible mechanism for arrhythmic events. And we know from a number of studies, this being one of them, that drugs such as empagliflozin can reduce the burden of extracellular fibrosis and thereby potentially reduce the risk of major arrhythmic events. So again, it's not just thinking about risk stratification, but it's also risk prevention as we go forward. And as these medications have now become mainstream, what we've also seen is the reduction in overall burden of sudden cardiac death, but highlighting the need for better stratification and, importantly, interception at an early stage. So, for instance, can we use this in someone who's gene positive, who hasn't necessarily manifested fibrosis, but who's starting to show some changes, for example, in strain or their size, early changes in their ejection fraction that may suggest that we can modify the disease process. So, having identified those patient cohorts with phenotypic evidence of dilated cardiomyopathy, it then puts us in a very strong position as a medical community to then be able to really home in on some of the genetic etiologies that we're seeing in these patients. If you've got a very well-defined and very well-characterized phenotype, you can then start exploring genetic studies to identify some of the mechanisms that have caused dilated cardiomyopathy in these patients. And the genetics, which is the next focus of my talk, has really been interesting in the why has this patient developed dilated cardiomyopathy, and going forward, can we use this information for building and assessing risk? The challenge we have in dilated cardiomyopathy is that there are a whole bunch of genes, of which the titin gene is probably the commonest, the titin being a spring-like protein that I'll discuss in a moment, but lamin and a few of the other genes also being very common, that all underline why these patients have developed the dilated cardiomyopathy. Really interesting here is seeing that defects can occur at many levels. So the nuclear envelope through the Z disc, the sarcoplasmic reticulum, over and above what's happening at the sarcoma. The other ones that I think are really interesting is what's happening at the desmosome, and then the cytoskeletal levels, where we're starting to see very malignant genes, for example, filament C. And also because from a phenotypic perspective, these can often be very closely associated with unique patterns of late enhancement, almost a band circular middle pattern of enhancement when you scan them. And these are patients that, a bit like the lamin genes, have a very, very malignant outcome. They're very predisposed to major rhythmic events. So the moment we see that pattern is scarred, the LV function is down, we would have a very low threshold, both with lamins and with filament Cs, to be thinking about an ICD, or at least starting that discussion with patients. And again, a number of studies have shown that where you have a gene, and this is from Jacopo Olivotto, where you have a gene variant as the underlying cause for the cardiomyopathy, these patients do worse than patients that don't have an obvious genetic basis for dilated cardiomyopathy. So again, we know that we need to be thinking about treating these patients differently. This is for a MACE endpoint rather than for heart failure specifically, or for rhythmic endpoint. And as we home in, what it highlights is that we have to move away from thinking of dilated cardiomyopathy as just one condition and really home in on these different etiologies. And I suspect that in 5-10 years' time, we will be taking a much more genetic or underlying etiology-centric management plan as opposed to one size fits all. And particularly, as one colleague said, if you've got a gene condition, your ultimate management is a gene therapy. And we've seen already in last week in Nature Med, Eric Olson's group, Cricket Seidman, where they're using gene editing technologies in HCM. And the expectation is that similar technologies will soon become available to manage our patients with a genetic basis for their dilated cardiomyopathy, titin being one of them. And if we can correct those gene abnormalities, you have the potential for a cure within these patients. But titin is the commonest presenting gene abnormality. It's an interesting protein. It's the biggest protein in the body. It has a whole range of diverse functions: sarcomeric assembly, passive tension, and signaling, first described in 1976. And what's very clear is that in most series, the most population-based series is the commonest genetic cause for having a dilated cardiomyopathy. The pathogenicity depends very much on where the mutation is. But what we also identify is that in this cohort, contrary to what we initially expected, they are very responsive to treatment. And we initially thought that these patients, when you put them on therapy, they will do badly, but actually they respond very well. but once they deteriorate, they tend to deteriorate fairly rapidly. So it's an important one to pick up, both from the patient management perspective, but also from cascade healing to family members. And how does titin affect the heart? Well, mutation? Well, at many levels, but it causes abnormalities to energetics, changes in fibrosis, increased arrhythmia, so changes are occurring. And again, at multiple levels, we see from the European Cardiomyopathy Initiative that those patients that have a titin truncating variant as the etiology for their cardiomyopathy do worse than DCM patients without the titin mutation. And also males and females have a difference in how they respond as well. The genetics has also been interesting because conditions that we've historically thought of as either due to a virus or just bad luck, we're now seeing that there is a mechanism for them, and peripartum cardiomyopathy being one of them, where there is an enrichment for the titin gene in a subset, so it's no longer a random abnormality. So about 10% of them, 10% of patients presenting with a so-called peripartum cardiomyopathy will have a titin truncating variant. Also, alcohol, again, what we described as alcoholic cardiomyopathy due to heavy alcohol consumption is no longer just straightforward. We do see that there is an enrichment for a titin gene within a cohort. About 13 to 14% of patients with so-called alcoholic cardiomyopathy will have a titin gene in several series. And therefore, it's important that in guiding these patients, it's not just abstention that's important, but it's also thinking about, is there a genetic predisposition to why they developed the alcoholic cardiomyopathy in the first place. The contrary view on that is that if you're going to drink heavily, just check that you don't have a titin mutation, but that's not guideline driven and definitely not something that we would recommend. Also, we see the same thing in cardiotoxicity. So patients with chemotherapy, again, there is predisposition and enrichment for chemotherapy-related cardiomyopathy. So again, in patients presenting with a severe DCM, our standard paradigm and workup in these patients would also be to test them for genetics. Also, from a genetic perspective, one of the things that we've often seen in the clinic is that within a family, certain patients will present with a DCM and other patients will present with a very contrarian phenotype, hypertrophic cardiomyopathy. So again, we're learning lots about how this is impacting and some of the factors that are driving changes and how that impacts then in the underlying etiology, and so not just thinking about your major gene abnormalities, your monogenic gene abnormalities, but as the field moves forward, also thinking about GWAS studies to build polygenic risk scores that look at a larger cohort of patients that develop the condition and answering the question about why, but also thinking about why in families different patients will develop different phenotypes. And that in turn, again, a number of things that have been identified that help to identify why we're seeing opposite direction changes. But I think the next step in genetics will really be building that polygenic risk score and checking that it's applicable not just based on ancestry, but also by gender, and identifying, using that then to build high and low risk patient cohort. Also, how has our understanding evolved? Myocarditis. We spoke about the fact that patients will present commonly with myocarditis after a viral infection. This is something that's sort of been seen much more frequently during the COVID pandemic. And historically, we've thought of this as being random. But what we identify in this cohort is two things, really. One is that there is an enrichment of two cohorts of genes. One is an arrhythmogenic cardiomyopathy gene in a subset of patients with acute myocarditis, and the second being a dilated cardiomyopathy gene enrichment. And this is seen overall in about 10% of patients. What's interesting is that these patients present slightly differently. So the arrhythmogenic cardiomyopathy genes, so your DSPs, your flat globin genes, will tend to present with a normal ejection fraction, but arrhythmia in conjunction with the acute myocarditis. Whereas your dilated cardiomyopathy genes, your titins, will tend to present with your low EF fraction in conjunction with the presentation. So again, it gives insights into how you build your your phenotype, you identify the acute myocarditis based on your imaging technologies, so your late enhancement, showing that classic mid-wall fibrosis, your acute inflammation on your STIR or T2 mapping imaging, correlating with histology. You then combine that with your genetic, and you then go back to understand why the phenotype is the way it is, and then use that in guiding your management. Of the genes that cause cardiomyopathy, we've talked about titin. The other one to be aware of is the lamin gene. And lamin, again, is particularly malignant. These are patients that have an increased risk of presenting with sudden cardiac death. And a number of groups have now looked at how we can use this to build a risk score. And again, this shows how we personalize our management of these patients beyond DCM to be more gene specific. So this is the LMNA VTA calculator, and Neil Lagdawala and colleagues have been very much involved in this, bringing in routinely clinically available data to work on who is high risk, who's low risk. So bringing that to the patient level, to the outpatient clinic level, where we can use this in a meaningful way. And again, the other gene that I mentioned was the filamin C. So filamin C, desmoplakin, these patients do badly. So wherever you see someone with these genes, I think they really need to stay under close follow-up. And early on, the question of an ICD versus no ICD should be very much at the fore. So we're seeing now that there are distinct phenotypes, there are distinct gene abnormalities, and really the next step is what switches on that gene, what's happening at the epigenetic level, what are some of those environmental stimuli that I talked about, that so-called second hit phenomenon, whereby these patients have a predisposition, susceptibility, but they don't manifest at birth. It's often when they're in their 20s or 30s that the condition manifests. So the next drive is really how can we understand better that link between the environmental stimuli and what's happening at an epigenetic level. So that's very much for the future, but an important lead driver of future work. But the paradigm I'd like you to think about in terms of the interface between phenotype and genotype is that there are multiple causes for dilated cardiomyopathy. It's not all genetics, it's not all environment, but where you have a big hit from the environment, so massive alcohol intake, a severe viral infection, that will be enough to reach the threshold of causing DCM. If you've got a major monogenic gene abnormality, that will be enough to take you to reaching the phenotype. But then you have a large spectrum of patients, the bigger spectrum where there will either be some sort of polygenic susceptibility and the environmental hit, or there will be a big environmental trigger and then maybe a smaller impact from gene abnormality. So I think this is a really useful slide from Ray Hirschberger, summarized from Ray Hirschberger, that kind of gives the idea of what is that gene environment interface and then finally, when one thinks about what are the future directions, again, it's really what do we know about ancestry? So we've talked lots about the presence of fibrosis, etc., but how do different ancestries behave? So again, this is another area that needs much attention, and again, work from Ray Hirschberg's group in the DCM precision study, showing that certain cohorts of patients do much worse than others. So non-Hispanic Black patients do much worse than Caucasians, for instance. So targeting why, is that later presentation, is that more severe phenotypes, is that differences in medication? All of that needs to be addressed. Also understanding that second hit phenomenon, as we talked about, what is it that results in that link between the susceptibility, the second hit to go forward. And then thinking about technologies, how can we use routinely available technologies, so the ECG, to predict better using neural network technologies to better predict who's high and low risk, so bringing that to the fore at routine clinical level with machine learning AI approaches to understand the risk. Who do we do a genetic testing in? If we do it in all patients, that can be challenging. If we do it in select patients, that may be more useful, but can we better identify who is most likely to benefit? Our current model and our current paradigm is that we would genetically test all patients below the age of 60 that present with a new onset DCM. In patients above 60, We would take a discussion with patients. Clearly, if there's a family history, that's something we would think about. But where we want to move towards, especially as the cost of genetic testing comes down, is really to test all patients, but work from Grid, from Pablo Lamata's group, looks at a number of predictors. So if there's a family history, low voltage on ECG, absence of left bundle branch block, absence of hypertension, these patients are more likely to have a positive yield on their genetic testing. So this shows how we can bring in some of the findings that we see at a routine level to try and identify who does and doesn't get testing. And then the other challenge we have that we talked about at the beginning is how can we harness all of these different tools to try and work out who does and who doesn't form into a high risk group, or who does or doesn't form into a risk for heart failure, and how can we harness all of that information. So recently we undertook a study, a multi-parametric study, where we looked at 426 patients. We brought together all of the genetics data, imaging data, proteomic data, lab ECG, clinical assessment data, and then using machine learning approaches and data pre-processing and then regression modeling, try and identify phenoclusters based on both their baseline changes, but also importantly based on outcomes. And what we identify is that there are different cohorts that behave differently. So there's a mild non-fibrotic cohort, and there's very much a pro-fibrotic, pro-metabolic cohort that does badly. And so approaches like this, I think, are going to be useful. Within this study, we validated those same phenoclusters in an independent cohort in Maastricht, and we see that these cohorts behave differently. But then how can we use this to then identify what are the really key predictors? No one is going to be doing all of these tests in every patient. That would just be difficult. And so again, what we can then do is use that to identify, using logistic regression type analysis, to really identify where is the money, what are the things that really help predict the biggest risk, or will give you the biggest bang for the buck. And as it turns out, a lot of it in this cohort and in this series is really very much from the imaging. So it's many of the things that you would have thought about. So what's happening to your end-stroke volume index, your RV dimensions, your LA size, these are really big and important predictors of what's going on, the presence of fibrosis, and then your serum creatinine. Within this model, the genetic testing didn't seem to be an important predictor. But as we go forward and as we replicate this work in larger series, it'll be interesting to see what happens in going forward. And specifically, in terms of how combining all of that information changes your decision making. Who gets an ICD, who doesn't, who goes on to what drug. Is this cohort going to be managed differently from this cohort? At the moment, we're putting all patients on all of the so-called Fab4 drugs, but will this patient benefit from lesser or different drugs? These are going to be important questions. And as the armamentarium of drugs that we have available increases, what we're seeing now is pushback from patients. Do they really need to be taking drug for the rest of their life? It's expensive. They're young patients. They're taking it for a long time. They have side effects, especially drugs like beta blockers. So how can we use this information to A, better identify what drug to what patient at what time? But B, how can we use this information to be more intelligent when we're running clinical trials? Can we select the right patient for the right clinical trial based on the underlying pathway and the underlying mechanism, so that we don't have the attrition that and the cost expense that we have at the moment whenever we think of a new study and a new agent? So I think that's very much where we see the future lying. I'll stop there, but I'm enormously grateful to you for the invitation to speak today, and I thank you very much for your attention.
Thank you so much. That was a wonderful lecture, and this, in particular, this slide, I think is so important. Like you're saying, we treat everyone the same way, and we put the medications without knowing if there's a better one for each person. This individualized medicine. Do you think that the analysis for this, it's going to be hard to have randomized control trials for each mutation, for each characteristic? Do you think the approach is with propensity matching, or you think these deep learning algorithms are going to be the way to kind of answer this question?
I think in the early phase, it will be the deep learning type type approaches. And in the longer term, large multi-center, multinational consortium are being built up. And as we build that data set, then I think we'll have much more specific data related to the gene. So I think it's one step at a time and then taking forward.
Thank you very much. There's a question. Hi, Purvi. It's Purvi Parwani. She asked a very important question that all of us that test for genetic testing get sometimes. When a genetic testing is shown a variant of unknown significance, and yet the patient has ring-shaped LGE on CMR, but no VT or PVC, what would your approach be for that patient regarding ICD if they don't meet the EF criteria?
Yeah, no, so that's a very good question. In fact, I spent the morning just dealing with exactly that question. The first thing is to make sure that your gene panel has good coverage. So have they definitely covered your filaments, the desmoplakins, your BAG3s? So that's the starting point. What do we mean by gene negative? The second thing is that if their ejection fraction is normal, but they have that circular ring pattern of fibrosis, I would present them in our MDT. I would have very close electrical monitoring. If we're not picking up any rhythm disturbance, their EF is normal. I would have a low threshold for putting a loop recorder in them, so you have really tight rhythm monitoring. If their EF is down, I think that's an obvious one. If their EF is poor and they've got that ring pattern, and if they have an intermediate or sort of 35 to 40 to 60, 35 to 45, 50 type EF, and they've got that ring pattern and any hint of non-sustained VT, I would start having that discussion with the patient about the ICD or not.
Do you re-image these patients in these conditions, or is there any time frame that you use?
So we do tend to re-image these patients. What we've generally tended to find is that in HCM, there is progression of fibrosis over time, whereas in dilated cardiomyopathy, it tends to be a little bit more static. So if they have fibrosis at baseline, we don't see that much evolution of their replacement fibrosis over time. But what we do tend to do is to monitor them for any evidence of LV dysfunction. And the role of imaging is to inform that side of things.
Thank you very much. We have from Daniel Lorenzati. He says, thanks for the magnificent lecture, and he has two questions. One question is about the age limit that you were mentioning for genetic testing. Is there any threshold or limit? You mentioned age of 60 that you use?
No, I hate to be ageist, and as I get older, the age threshold increases, but it's purely a pragmatic one at the moment based on cost. We found lamin mutations in 70-year-old patients who've then gone on to have major rhythmic events. So I don't think age is the cutoff. I think that the really key thing is family history. If they're 90 and they've got a family history, I would still suggest testing them. Obviously, if it's practically inappropriate to do so. So I think family history, I think how they presented, their imaging parameters are more dominant. Our geneticists at our institution take some age cutoff purely because of financial considerations. But as we find the cost comes down, which it has dramatically, that age barrier will drop even more significantly. And it's not a guideline thing, it's purely a pragmatic thing.
Is it widely covered there, the genetic testing for patients?
It is covered because we have an NHS system. The testing is centralized. So whilst there is a degree of control and making sure we don't order it on all patients, it's generally fairly widely available, yes.
Thank you. And he also has another question about these patients have mixed cardiomyopathy that sometimes is very hard for us on CMR. What can you comment on the patients have bystander CAD or these mixed ischemic and non-ischemic patterns? Should we stratify the risk differently in this subgroup?
Yeah. So as these patients with dilated cardiomyopathy get older, they are going to develop coexistent coronary artery disease, and we frequently see that. Secondly, so that's epicardial disease. Secondly, patients that have a very poor LV are at increased risk of getting thrombi and therefore having an embolic cause for their infarct. We've looked at our own series of about 200 patients where they have a mixed pattern, and they do seem to have a slightly increased arrhythmic risk. We're still analyzing that data to understand exactly what the incremental risk is. But in the ones that have both a DCM and in patients that have, let's say, an existing DCM, but then go on to have an infarct. So we're secure that they had an initial diagnosis of dilated cardiomyopathy, and 10, 20 years later, they then develop an ischemic event that we know is epicardial related. Those patients tend to do badly. The patients that have that tend to have 1 to 2 segments of smaller infarct anecdotally tend not to do so much worse than those without any infarct. But we are analyzing that data at the moment.
Are you quantifying and you providing a quantification of the burden of LG in these patients, or not?
So historically, we found that the biggest signal is in the presence of fibrosis, and unlike the infarct setting or in HCM, where 15% seems to be a cutoff, these patients with dilated cardiomyopathy, and about 30% of our DCM cohort will have mid-wall fibrosis. It tends to be a smaller amount, and therefore its ability to discriminate between higher and low risk is much more challenging. Does 2% mean a greater risk than 5%, for instance? So at the moment, we have seen that in large series there is some benefit from the amount, but actually the big signal is just the presence. So the bulk of our risk stratification is on the basis of presence versus absence.
Great, thank you. And we have some questions from other modalities of imaging. Aldous Kenon is asking, any role for scar entropy analysis by CMR to further re-stratify these patients?
Yeah, so again, it is something that we've looked at. Time didn't permit me to show you some of our data on that. At the moment, it doesn't appear to be strongly incremental. So let me rephrase that. When we look at entropy, it does seem to be an important predictor of arrhythmic events, but it doesn't appear to be incremental to the presence of LG per se. So for the moment, it's not something that we think it probably has utility, but it's not something that I think it will stand just on its own as an independent predictive factor. I think where we have to be smart is how we can use it to add value in patients that have fibrosis, as opposed to using it on its own.
Thank you. And from Ibrahim, what about the use of MIBG SPECT? Is that dead, or are we still using it?
Again, where I think PET technologies are going to come in, MIBG SPECT specifically, we haven't tended. I have relatively little personal experience of it, so I haven't really used it. What I think will be interesting is some of the new PET tracers, some of the fluorine F18 type tracers, where we can look at fibroblast activity. With MR, it's kind of telling you what has kind of happened. But if we can tell what is also happening, in other words, looking at that fibroblast activity before the fibrosis is developed, I think that could be interesting. So particularly, for instance, from a research perspective, perhaps, but in our gene positive phenotype negative patient, before they've developed fibrosis, can we use this to look at disease activity and identify the utility or intervention early on in a research setting, but that can then be extrapolated to the clinical setting.
Thank you. We're getting a lot of questions. We'll go through a few more if you have a few minutes. So from Dr. Carl Diaz, he's a research fellow at the Advanced Heart Failure Unit. He says, great talk. And he asks about the TTNTV carriers. When and how should we screen for phenotype, and how long should we follow up these phenotype, gene positive, phenotype negative patients?
So if I've understood correctly, the question is, you've got someone who's gene positive, they're phenotype negative, what should be their workup and follow? Did I understand that correctly?
Yes, that's correct.
Yeah. So our own practice is that if they're gene positive, phenotype negative, we tend to see them on a yearly or 2-yearly basis. We don't stop their follow-up over time. Again, these are relatively new findings, so we're still learning much over the last few years, but our own practice is we tend to see them on an annual basis. They'll get an annual MR scan, ECG, bloods, and then follow up. And we educate the patient that if they have anything that we would consider to be a second hit, so if they become pregnant, or if they've had a bad viral infection, they've needed chemotherapy, to let us know early on. And where it's a planned intervention like chemotherapy, we would make sure that they get good quality imaging, baseline markers before they start their treatment.
Are you starting medical therapy in them, or do you use any markers for that?
At the moment, no, we're not. We're starting a study where we're looking at the utility of therapy in this patient cohort. The problem is that many of these patients, at the time now that they're picked up because of cascade screening, they'll often be in their in their adolescent years or young adults. The challenge is how long do you treat them for, given that some of these patients won't manifest till they're 50 or 60, others till they're in their 30s. The late 20s, 30s seems to be a common age for predisposition. So I think it's a really important question, but the challenge is how early and for how long. So it is something that when my colleague Brian Halliday is setting up a large cohort to try and study, ultimately I think the real money, before we find out the answer to empirical oral therapy, is can we actually think about gene editing technologies to prevent the condition? I think that's where the real money is and where the focus will be.
Yeah, I agree. And our last question from Yogita Roslani, our heart failure attending. She asked again about this gene positive versus variant of unknown significance with cardiomyopathy. So what do you do? What recommendation do you tell to the patients with these variants of unknown significance? Do they have the disease? Do you screen the family members?
So a number of things. So let's say we've done all the genes and they still have a VUS. That we would inform the patient that we picked up a VUS. We don't know its significance. We have a program of continual review of whether the VUS is now being deemed pathogenic or likely pathogenic or continues to be a VUS. So every year or so, there's a systematic reanalysis of the data as we look at larger data sets, international cohorts in the first instance. The second thing is that we would still cascade screen their family members, but we from an imaging perspective, but we wouldn't test them from a gene perspective where we've got a VUS, and we would continue to keep them under follow-up, and we would educate them that we've picked up something that at the moment we don't understand its pathogenicity. We need to keep under review. So we would continue with their imaging follow-up. We would still cascade screen their family, but from an imaging rather than from a genetic perspective. I hope that answers the question.
Yeah, perfect. Do you have any problem with the approval for these imaging studies, or there's no problem there?
No, I mean, again, partly because of the nature of our hospital, but also across the UK. At the moment, cardiac MRI is well funded because we have a National Health Service. Screening is very much encouraged and therefore not an issue. It's not an insurance-based study issue. So in practice, it's not a problem.
Great. Well, thank you so much. This was wonderful. I highly enjoyed the lecture, and so we hope to see you in person in New York. Let us know if you're
Wonderful.
around.
I greatly look forward to that, and thank you very much both for the invitation and the opportunity to talk.